Our first speaker is Dr. Vicky Mccachney, who is a clinical psychologist at Imperial and a member of the Charing Cross Diabetes MDT. Just before she starts, before I hand over to her, I just wanted to get the audience's thoughts on what comes to mind when someone mentions the psychological aspects of diabetes. Thanks everyone for voting. So as you can see, actually, the term psychological aspects of diabetes really encompasses a number of things, running right from acceptance of diagnosis to needle phobia to fears of complications such as having a stroke and fear of hypoglycemia. And thank you very much, Vicky, for coming to talk about what is a really quite a big topic in quite a limited amount of time. So I'm going to hand over to you now.
Thank you, Harriet and Kavita, and thank you so much for inviting me to come and speak today about diabetes psychology. I really appreciate the opportunity to come and think about these things with you, so thank you for taking the time to come along and listen today. As Harriet said, I'm a clinical psychologist specialising in type 1 diabetes, and I sit within the Diabetes MDT at Charing Cross Hospital. It's good to see lots of familiar names of people who are either Charing Cross at the moment or who have passed through in months gone by, so nice to see you. I'm going to talk today a little bit about I suppose some of the typical psychological difficulties that people with diabetes might have, what those might look like, and a little bit of sort of advice and recommendations about what you can do, how you can support your patients, and then also some information about other services that you might be able to refer people to. I'm very mindful that not everybody will have access to diabetes psychology, so I will bear that in mind as I go through the talk and hopefully sort of help people to think about options, you know, if that isn't available in the service that you're working in at the moment. It's great to see your thoughts that came up with the word cloud earlier about sort of what comes to mind when you think about the psychological aspects of living with diabetes. Why is it important for us to think about this? I think we don't have to think for long about the idea of living with diabetes to realise that it's really challenging and complicated health condition for people to live with. We know there's a significant evidence base, and also just intuitively we have seen clinically that if somebody's living with mental health difficulties, that is likely or possible that it might have an impact on their diabetes self-management. And the reverse is also true. We know that living with diabetes is challenging and that can have detrimental impact on somebody's mental health. I hope it's the case that we all want our patients to do well emotionally as well as physically, and we know that these two factors are kind of inextricably linked. I'm sure many of you will think of patients that have been under your care or that you know who know everything that they need to know about the self-management of their diabetes, but for some reason that hasn't translated for them into their self-management being where they or you want it to be. We know that information provision is of course necessary, but sadly not sufficient for people to have kind of optimised self-management. And I think another thing that I really want to highlight is actually the psychological aspects of living with diabetes is sometimes a thing to be sort of somewhat outsourced to a mental health service or a diabetes psychologist, but actually it really is everyone in the MDT's responsibility to think about people's psychological well-being as well. And I hope that this talk will help you to feel more confident about taking that responsibility on. Many people will talk of diabetes distress and diabetes burnout, and these are sort of definitions of those concepts. It's important to say that these are different to depression. People can experience both at the same time, of course, but the idea of diabetes distress and diabetes burnout is that they are specific to diabetes rather than kind of pervasive difficulties that somebody might be experiencing in the rest of their life. So it's not uncommon for somebody who's experiencing diabetes distress for every other area of their life to feel kind of okay or sort of manageable for them, but the difficulties can feel quite specifically related to diabetes. What does it look like? What does diabetes burnout, diabetes distress look like? These might be some of the things that you hear your patients say if they are experiencing diabetes distress or diabetes burnout. So maybe there's that sense of somebody's just kind of sick and tired, they're exhausted with living with diabetes. It feels just too much, it's just one thing after the next. We might see some changes in somebody's self-management. We might see a creeping up of the HbA1c. We might see that somebody's perhaps a little bit less on it in terms of calculating their insulin dose according to their carbohydrate. We might see that somebody's perhaps taking their injections a little bit later than's been recommended. Not always, but just sort of little challenges like that might be early signs that people are struggling a little bit and feeling a bit burnt out with their diabetes. These are other common difficulties that people might experience when living with, well, in this case, type 1, although some of these will, of course, also be present in type 2 diabetes. And many of these things I think you sort of highlighted really on the poll at the beginning. So just to sort of pick out a couple of these, we know that fear of hypo is a really common thing that can affect lots of people. I suppose there's different ways that might manifest. Some people might be very fearful of hypo and they might choose to run their blood glucose pretty high to feel that they are safe and sound from avoiding hypos. Other people might say, well, actually, I'm running my blood glucose at a level that I'm happy with, but I'm having kind of quite sudden or unpredictable hypoglycemia, which absolutely terrifies me. I'm worried about what happens when I'm asleep. I'm worried about what happens when I'm out and about in public. So lots of different areas that people might struggle with their diabetes. And of course, these factors will all kind of connect with other areas of life as well. If some other part of life is difficult, these difficulties might feel more concerning or pressing to somebody. Important to highlight that these difficulties can be seen even in people who perhaps don't come to a clinic appointment and disclose this to you, or even in people who have an HbA1c that is kind of on target or around the level that you would want or expect it to be. That doesn't necessarily mean that the person is sort of feeling okay in the way that they're living with their diabetes. So just as a sort of illustrative example, let's imagine you've got a man who comes to see you in clinic, he's got an HbA1c of 96 and you're sort of tasked with thinking about, okay, what might be going on here, how can I support him? I think in some ways this is an obvious slide, but I think it bears repeating the fact that actually there are lots of reasons that this gentleman might have an elevated HbA1c. Here's just a few that came to my mind. Social difficulties, so actually it's difficult for diabetes to feel like a priority in this man's life, even though he'd like it to be. He's perhaps caring for a relative, he's struggling to find work, or indeed he's working extremely hard and work doesn't sort of allow for it. Maybe there are some gaps in his education and he's not absolutely sure how to manage his blood glucose in a way that's been recommended. He might be fearful of hypo, one of those people that we mentioned before. Maybe there's some difficulties that mean that it's hard for him to manage at work. Maybe he's not being given the breaks that he needs. He might have a learning disability or some kind of learning need that makes diabetes management difficult. Some of it's pretty complicated, and it can be helpful, can't it, to be sort of relatively numerate in terms of understanding those things. He might have low mood. Actually, he might be struggling with lots of different areas in his life, and diabetes might be one of those areas. Maybe he is deliberately withholding insulin to maintain a low weight. Or maybe he's somebody who's kind of experiencing adjustment difficulties or diabetes burnout, and he's just hating his diabetes and is trying to ignore it. I recognise that in some ways, like I said, these are all kind of obvious things, but actually, if we want to support our patients to do well with their diabetes self-management, we need to do a little bit of digging to work out what is going on for the individual patient in front of us to help us make sure that we can support them as best we can. And then think about, well, actually, what does this person need? What does this person need at the moment to help them It may be that actually educational practical support is helpful. So thinking, for example, back to that example of fear of hypo that we thought about before. If somebody is having debilitating hypoglycemia and is very fearful about that, probably in the first instance, the thing we want to do is try to reduce that, rather than perhaps refer them to mental health or psychology services. Actually, probably what that person needs is some practical support to try and stop that happening, to keep them safe. And we would hope that that would reduce their anxiety. It might be that the person does need support from mental health services or from a diabetes specialist psychologist, and we'll be thinking a bit more in a minute about kind of how to make some of those decisions in terms of where somebody might need to go for their support. But I think the headline here is make use of the MDT. We have MDTs for a reason. Nobody is an expert in everything. MDTs can be helpful to sort of puzzle things out together, have different perspectives, but also we can make use of other professionals in our team who might be able to offer our patients something useful. Just to say a little bit about clinical health psychology or diabetes psychology. So that's what I do within the Charing Cross MDT. Some of you will have clinical health psychology in your diabetes team, some of you won't. I'm also mindful that in some services, clinical health psychology is present, but not necessarily sitting within the MDT for one reason or another. So if you're not sure, ask your colleagues, because there may still be somebody out there to sort of speak to and maybe to see your patients. So generally speaking, clinical health psychologists work with people whose psychological difficulties are specifically related to diabetes and its management. Particularly important is that we want to see people where knowledge and expertise in diabetes is really central to working safely and effectively with the person's difficulties, and that might also include kind of close working within the diabetes MDT. So for example, if somebody has a difficulty and that psychological intervention is likely to involve making changes to their diabetes treatment or their diabetes regime, it is going to be a safer way to do that within the MDT with the diabetes psychologist who is a specialist in working with diabetes, but also has the support of the MDT for making those decisions. And just to say, we don't just do one-to-one psychological therapy. We also offer teaching, supervision, consultation, and also MDT discussion. So oftentimes clinical health psychology, sadly, is a bit of a limited resource. We are delighted to work with people one-to-one, but we also recognise that isn't always an efficient use of psychology. So we also want to support and upskill the rest of the team, I suppose, in thinking about how they can support their patients and how to refer people on. Many of you will have heard of Iapt. This stands for Improving Access to Psychological Therapy. These are primary care, adult mental health talking therapy services that offer support for problems such as anxiety and depression. People can self-refer, actually, or you can refer people. It's very straightforward. It can be done online. If you just search online for the borough within which the person's GP is based, and Iapt, some of them have brand names, but they've all got websites. You can refer online. The person can phone up or self-refer, so they don't need to go back to the GP for that, although they can if they want to. And although this is a general adult mental health service, most Iapt services, particularly those in the North West London area, have recently been really increasing and improving what they offer to people with long-term health conditions, including diabetes. So they will have clinicians there who are experienced in supporting people, perhaps with kind of adjustment to diagnosis, diabetes distress or burnout, and that sort of thing. As I said before, I recognise that some of the people on this call won't have access to clinical health psychology. The Iapt services, certainly that I've worked with, have always been very responsive. So if you're not sure if a referral is appropriate, give them a call and ask, and they should be quite well placed to let you know if they think that's something that they would be able to help with. So they're a great resource, and lots of fantastic colleagues there who can give our patients a bit of a hand with those difficulties. Some of you might have heard of the single point of access. So mental health trusts have these are secondary care mental health visits. So here's a couple of numbers for kind of on the patch, but again, widely available. These numbers can be called 24/7. You can refer to SPA for a mental health assessment. You can also call them for advice, and I historically have found them hugely helpful. Perhaps if I've got a patient with more sort of complex or severe mental health difficulties, they're very well placed to offer kind of guidance in terms of what services might be available. And as I said, they will do mental health assessments as well and onward referral. If you're concerned about risk, these services are really, really helpful services to contact. And actually just to note as well that those numbers can also be given to patients as crisis numbers. So if you have a patient who you are concerned about, you feel safe to let them go, but you want them to have a number that they can call, then the SPA numbers can also be used as crisis numbers for your patients. What I also want to emphasise is that the psychological care for people with diabetes is not just about onward referral or just about kind of MDT discussion. I want to kind of emphasise and reassure you that actually this is something that we all do. It is everybody's responsibility. You have the skills to be, validating, empathic, normalising, reassuring. And I don't think the information and practical support that you offer can be underestimated. Actually, if somebody feels equipped to self-manage their diabetes, that is likely to be really helpful for them in managing the distress that they might have from living with their condition. And this idea about sort of being sort of collaborative with the patient, being curious about what are the barriers that are going on for them, how can we work together to try and overcome these? All of these things are supportive and will help people with their sort of psychological difficulties that they might be experiencing, or indeed help to prevent those psychological difficulties. I wouldn't be surprised if there are people listening at this point thinking, do you realise how much I have to get through in a consultation? This feels a bit much, and I understand that. I understand that can be a concern. I know appointments are not long, and there's a lot to get through. And we recognise that sometimes this can feel like a bit of a luxury, to be honest. I think what I would say to that is, yes, it can, but actually we also know that, as we said before, knowledge and information is necessary but not sufficient. And actually, if we can use a bit of the consultation to work out what are the psychological barriers for this person, what are the difficulties, what's going on, how can we provide education, support, signposting, we may find that what feels like sort of an extra 10 minutes could actually be the sort of key that kind of really helps to improve things for that person, which would be great, wouldn't it? When do I refer to mental health services? How do I know when to do that? Oftentimes you might see people in clinic who are having a really difficult time with their diabetes, but maybe the kind of primary issue isn't directly related to their diabetes. Maybe they've had a bereavement, or maybe they've got relationship difficulties, or they're experiencing quite pervasive anxiety or depression. In those cases, we would anticipate that there would most likely be an impact on the person's diabetes self-management. However, we would hope and expect that if they went to their local adult mental health service, as they are supported with their anxiety, their low mood, whatever those difficulties are, we would hope and expect that the difficulties that they're having with their diabetes would improve as those other difficulties improve. So generally speaking, we expect mental health difficulty to have a challenging impact on diabetes. We hope that a mental health support intervention would help with both of those things. I make that sound terribly straightforward, and in a busy consultation, that isn't kind of always the case, is it? These are some screening tools that are widely available online that might help. So there's the PAID, which many of you will be familiar with, the Problem Areas in Diabetes Scale. There's a few different versions available, 2, 5 and 20 items. There's the GAD-7, which is a 7-item measure of anxiety. And then there's a PHQ-9, a 9-item measure of depression. Again, it's okay not to be sure. We often bring these sorts of people to the MDT for a discussion. Somebody else might have met the patient before, know them quite well. Speak to the diabetes psychologist as well. These things aren't always clear cut, and it can be helpful just to get our heads together about what might be the most useful thing for somebody. So do make use of that. Hopefully, we're a relatively friendly bunch, us diabetes psychologists. We're always happy to sort of chat things through with people and kind of field queries. So do get in touch if you're not sure. And that's not to say that we will always be sure. And sometimes there is an element of kind of thinking things through, trying things out, and sort of having a bit of an action plan, really. So this is the PAID 5. I believe it's available online. It's free to use. Generally speaking, the advice is that somebody scoring 8 or more on this, that might be suggestive of elevated levels of diabetes stress or diabetes distress. Again, asking somebody to fill this in can be a helpful information tool to work out what the difficulties are and where the focus of your consultation might need to be. This is GAD-7. So it's a slightly blurry version, but again, this is a measure of anxiety, which again is freely available online, and people can be given to help guide you and them to get a sense of things. This is the PHQ-9, the depression measure. Just bear in mind that the bottom one is a question about risk, so worth just having a bit of a look at that, or talking to somebody about that if you are worried about those aspects. They're not diagnostic, they're screening tools, but these are the sort of suggested cut-offs for what we might be looking at based on people's scores on the GAD-7 and the PHQ-9. Fine, so somebody's filled it in, they've got a high score. What next? These might be questions that are helpful to ask just to get a bit more of a flavour of kind of what's the content of this person's distress. Does this feel sort of diabetes-y? Does it feel different to diabetes? This can be helpful if you want to take it back to the MDT, just have a little bit more information to sort of share with the rest of the team. But as I said at the bottom there, don't just rely on those tools. Use your clinical judgment in addition to those tools for sort of decision making and thinking about kind of further support. There aren't loads and loads of guidelines or information out there about things to think about from a psychological perspective when we're thinking about starting somebody on insulin pumps. But I think just a couple of things to say is that it is not uncommon, as I'm sure you know, for people to have expectations of the pump that aren't entirely accurate. Maybe they've not had an opportunity to read something, or they've heard something and slightly misunderstood it, or whatever it is. So, for example, they might think that the pump sort of calculates their insulin for them. And it's very understandable and common for people to have a few concerns about the pump. I don't like the idea of something being attached to me all the time. What if I knock it? Those sorts of things. If we want pump therapy to go well for somebody and to be a success, it's really important that we try and learn a bit about what are people's expectations and understandings of how the pump works. Do they have any particular concerns? This will help you to think kind of collaboratively with your patient about how to manage those. Just be aware that there might be some circumstances in which somebody's mental health difficulties might impair safe use of the pump. I'm thinking about psychosis, severe anxiety or depression. If somebody's under a mental health team, you might do well to drop their care coordinator or psychologist or whoever a bit of a line to have a bit of think about whether now is the right time or what might help to make that a success. At the same time, to sort of flip that on its head, we do know that actually insulin pump therapy can help to reduce, for example, somebody's low mood from the challenges and burden of living with diabetes. So it's a thing to sort of think about and reflect on and discuss with the team. There are instances in which it might be helpful for somebody to consider psychological therapy before starting on a pump, whether that's general mental health psychological therapy or diabetes specific. It might be worth just thinking about that in some cases for some people. What I'd like to do now in the last sort of 10 minutes or so is just give a few examples of kind of what we're talking about to hopefully make this feel a little bit more kind of real, as it were. So let's imagine you've seen a 45-year-old man in clinic. He's had 27 years of type 1, the HbA1c is 78, and you've noticed from the notes and previous appointments that he's had that actually that's kind of crept up a little bit over the last 2 years. He's kind of describing difficulties kind of motivating himself to monitor his blood glucose. He's more sort of guessing a bit with the insulin. And he's just reporting feeling really fed up with his diabetes self-management. He's feeling unable to get it right, not really sure, you know, how much he wants to continue with the self-management. It's all feeling quite difficult. So you're thinking, okay, I think he might benefit from some psychological support. So I thought it'd be useful just for us to have a conversation for 3 or 4 minutes, just to think, what could you ask him to help ascertain which service might best meet his needs?
So was this patient having any additional symptoms of depression? Has that been explored at all? And again, thinking just about harm, I guess, always at the back of your mind in any sort of psychological assessment that you're going to do of the patient.
Yeah, thanks, Harriet. I'd agree with both of those things. So actually, are we looking at a kind of depression type picture here, and also bearing in mind if he is having any thoughts of harming himself, and if he is having those thoughts, whether there's any kind of plan, just I suppose get a bit of a sense of what we're dealing with and whether we need to take action with that. Yeah, absolutely. Don't know if anyone else has got any thoughts on that.
The other thought we had was around, maybe, you know, I suppose this is more about tools that might help, but sort of diabetes technology, had that been explored with him previously? Yeah,
absolutely. And I think that's a really nice example of thinking kind of holistically and about all the different bits and bobs, actually. Yes, there might need to be some sort of psychology assessment-y stuff, but there also are there kind of diabetes treatment things that would be helpful for him. Absolutely, yeah. I would just say there isn't a sort of a right or a wrong answer to this, so please don't be shy if you've got a thought of what you might want to ask. It's not the case that, you know, there's a sort of a yes, no, do ask this, don't ask that kind of situation here. Oh, I like that question. If there was one thing we could help you with your management of your diabetes, what would it be? That's a really nice question. It's kind of sort of putting it back on him, actually. You know, we can see this is difficult, but actually, what do you want? What might be helpful? Yeah, lovely. Lots of great questions. Hopefully you can see my slides again. Can you? Is that right? Yes. Great, fantastic. Yeah, I think these are all lovely questions that could be asked. So let's imagine we've asked some of those questions and we found out that actually 2 years ago he lost his job and he's been feeling quite low since then. His relationship with his son has deteriorated. He's kind of reduced motivation for cooking, for socialising. Thankfully, there aren't any risk concerns, but actually based on all of this, it sounds like this is somebody who's experiencing kind of low mood and depression, and very understandably, that's having a difficult impact on his diabetes self-management. So we would probably discuss this in the MDT. And I think in the first instance, we would say, let's try, with his consent, if he's up for that, referring this gentleman to Iapt. We hope and expect that they will be able to serve him very well with some talking therapies for low mood. Perhaps we'll see him again after he's done that. We hope that things will have improved since then, but if not, then we can problem solve again and have another think about it. On to another example. So this is an example of somebody that I might see. A 35-year-old man with type 1 since he was 12 was seen in clinic, had an HbA1c of 38. Great, you might think, lovely. But actually a little bit more kind of questioning reveals that this is a man who very high achieving, describes himself as a bit of a perfectionist, and maybe a bit of pre-existing anxiety, but not really kind of been on the radar of any kind of mental health services or mental health support. And he described this kind of wanting to have sort of perfect blood glucose readings. You know, I want to be between sort of 5 and 6 all the time. Otherwise, I get very angry with myself. I get very cross with myself. I feel very disappointed. And he describes a bit of kind of anxiety about the future as well, about his health in the future. What that looked like in terms of his diabetes self-management was that there was a lot of monitoring on CGM, which was kind of interfering with focusing on other tasks, you know, alerts popping up and kind of acting on those. A lot of kind of early overcorrections of rising blood glucose levels, sometimes correcting as early as sort of 7. And unsurprisingly, unfortunately, this was associated with a lot of hypos. And we were sort of moving towards a situation where there was a concern about kind of impaired awareness of hypoglycemia. So this was brought to the MDT, and it was felt that this was appropriate for clinical health psychology. The reason for that is that an intervention like this would inevitably require quite a lot of diabetes knowledge and expertise. It would require collaboratively with the patient wanting to eventually make some changes to hopefully the way he managed his diabetes, and we would want to be doing that in the sort of safe context of the diabetes MDT. So I saw him for 10 sessions. We did a sort of a full assessment of kind of what was going on, what was sort of maintaining those difficulties, and these are some of the things that we did together. So we made a point of linking in with the wider MDT for some diabetes education. He had some beliefs that a very transient high was going to be problematic in terms of sort of long-term health complications. So, you know, being at say 8 for kind of half an hour after a meal would, you know, would sort of risk his health in the longer term. He maybe also, I think, needed a bit of support around sort of what will happen to blood glucose levels naturally if they're left, and about sort of not stacking insulin as well. He and I spent a lot of time kind of working on those high standards, working on the self-criticism and frustration around blood glucose levels that weren't where he wanted them to be. And there was quite a lot of work around sort of trying to help him to be more compassionate towards himself and less self-critical, trying to get a bit of distance from those self-critical thoughts, but also being more kind to himself. Practically, there was a lot of work on reducing the checking of the CGM, and just kind of working on what we might call kind of sitting with a slightly higher reading, and building his kind of psychological skills in tolerating those difficult thoughts and feelings that were coming up for him. So previously, you know, the level might have gone to 9, immediate correction and then a hypo, and partly that was about trying to avoid difficult thoughts and feelings that were associated with being at 9. You know, this means I am this means my future will be that, and part of the work was just about sort of sitting with that, managing those thoughts, challenging them, being compassionate towards them, and helping him to feel more comfortable at a slightly higher level. So his anxiety and depression reduced. The HbA1c increased, which I recognise isn't typically an outcome we look for, but it can be in these types of situations. He describes sort of, I'm better able to sit with those levels, I'm less inclined to intervene. I think in this sort of situation where somebody's perhaps got a lifelong tendency towards kind of high achieving, perfectionistic, self-critical way of being, it's always going to be a bit of a work in progress. I think certainly through 10 sessions, you know, we can't have a magic wand and alter that for somebody, and often people do see that as quite an adaptive thing as well, so it can be quite strongly held, but kind of continuing to work on being kind to himself about those blood glucose readings. And I think there was a sense that diabetes felt less emotionally and practically time consuming. You know, I'm not having to, or feeling that I have to kind of look and check my CGM every sort of 10 minutes or whatever, and I can just sort of not have those worries popping up quite so much. So that's kind of an example of somebody we might see in diabetes psychology, and hopefully that will sort of make sense as a bit of a whistle-stop tour. Thanks again for inviting me to come and speak. And just to summarise, we know that living with diabetes is hard. It is normal for people to struggle and find that difficult. It's really important to think about the role of psychological factors, and not just for the people that seem distressed. You know, we all have psychological factors that affect how we see the world, the decisions that we make, and that doesn't just include people who are struggling with things or feeling distressed. Use those open questions and your sort of clinical skills to try and sort of learn about somebody's situation, to kind of tailor the support that you give them. You are part of their sort of psychological support, and please don't forget that. That's a really important role that you do have, so don't kind of understate that. And also remember to kind of work with the MDT to think about what that person needs and what will serve them best. I will stop sharing my screen now to see if anyone's got any questions, any comments, anything they disagree with. So I will stop sharing now. But yeah, thank you so much for listening. I hope that was useful.
One question we had was, which cohort of patients would you think need psychological support before we refer them for pump therapy?
I've sometimes seen people who've been referred to me just because actually they're just not sure if they want to go on a pump, and they want the opportunity to think that through. They want the opportunity to think about, how will this help me? What might be the hindrances? What might be the difficulties? What are my questions that I want to ask? I do think if somebody is living with mental health difficulties, that needs to be thought about a little bit more carefully, and particularly if there are kind of risk issues, and you know, for example, if somebody's feeling low in mood and there might be difficulties with motivation, or if they're very anxious and there's a sense that they might feel quite overwhelmed by the pump, it might be prudent to think about, well, that doesn't mean they can't have one, but it might be prudent to think about, well, how can we make this go as well as possible for this person? What might be helpful to put in place? So it might be helpful for them to see clinical health psychology prior, just so they can think about, how can I make sure this goes well and is a success? What are my risk factors or my vulnerabilities, as it were? And how can I sort of keep an eye on those and work with my team to make sure this goes well?
That's really good. I think we have one question from the audience, and that is, if you don't have a health psychologist in some hospitals as part of the team, do you have any suggestions or resources for diabetes distress?
Yeah, it's a really good question. I think, as I said, I think often the Iapt services, and actually probably all the more so in the areas where the diabetes MDTs don't have a clinical health psychologist, can be quite well equipped to offer guidance and support, or kind of groups. Some of them will offer groups around diabetes distress, so people can sort of meet together as a group and sort of work through resources and materials. So I think Iapt is a great resource. Just in terms of, is that also a question about kind of resources that people can be given as well as sort of signposted to?
I think so.
Yeah, that is a good question. I'm just trying to think. I know that Diabetes UK has lots of kind of resources and materials on their website, which can be helpful to point people in the direction of. I'm just trying to think. There's nothing else that comes to mind at the moment, but I certainly know that Diabetes UK do have some really good resources on their website. I would also say that actually even just naming it and normalising it, explaining to people, like, we understand that this is hard. I recognise that's not going to sort of be a magic wand, but actually be surprised how important and helpful it is when somebody's doctor just kind of acknowledges that and gets that. I think it can really build the working relationship, but I think it can also help people with that struggle. Again, I think there can be a bit of a fear of kind of opening a can of worms in a short consultation, and we understand that. But actually it can be really, really helpful just to sort of acknowledge that and name that, I think.
Thank you for a great talk. I recently was involved in the care of a young woman who was newly diagnosed with type 1 diabetes, which is obviously a time that a lot of patients experience a lot of distress. And on further questioning, it seemed very clear to me that she'd had years and years of really disordered eating that she'd really never sought help for. And I was just so worried about her, and she had so much going on with the diabetes side of things. I felt like the psychological aspects were sort of lower down in the priorities, and I didn't know how to raise that because you know, just from a gut instinct, I just felt it was a real problem. Are there any sort of pathways or specific psychological clinics for these patients, or even just resources that you know of?
Yeah, that's a really good question, and I think it's difficult, isn't it? Because I think my sense is that we know that lots of people with diabetes, you know, there is a higher proportion of eating difficulties amongst people with type 1 diabetes, and if you've already got that kind of a history, a type 1 diabetes diagnosis is going to be kind of extra challenging, isn't it? On top of that. King's has a type 1 diabetes eating disorder service, which, if you look online, can be kind of referred to. You can refer your patients to that service. They're, again, very responsive, very helpful, and a really good resource. I think if you have questions like that, I think there are also kind of general eating disorder services. And I think they are increasingly becoming aware that perhaps the referral criteria for somebody who's living with type 1 diabetes might need to be different to their general referral criteria, because I think I would argue that the threshold is perhaps a little bit lower, or should be a little bit lower, if that makes sense, in people with type 1 diabetes. But I think in terms of the eating stuff, and I think it's a particularly kind of vulnerable time, isn't it? If you've just been diagnosed, you almost feel like you want to set good patterns in place to begin with, I suppose, so that person is supported with that. So if clinical health psychology is around, that's an option. If it's not, I think the King's service could be a good option in terms of kind of referral and support and advice.
Vicky, just on a practical level, are you limited in the number of sessions that you can offer a patient, or can you offer them as many sessions as they need?
Yeah, that's a good question. So sometimes I will only see people for 2 sessions and that's all they need. I think probably the most I've ever seen anybody for is an assessment and 16 sessions. So there is a sort of a practical limit in that, of course, you know, there's going to be a bit of a waiting list and that sort of thing. On average, I would say I see people for perhaps between 6 and 12 sessions. Occasionally I see people for more. If we're in a situation where it feels like they need more sessions, we might be moving towards thinking about a longer term psychological therapy service, I suppose, if that makes sense.
And those sessions typically would be sort of every week, or would they get, you know?
It's very variable. Some people it's weekly. I've got a couple of people at the moment who we have been working fortnightly, and now they're sort of off and away and kind of working on things, but we're sort of having some spaced out review appointments kind of once a month, once every 6 weeks for the last 2 or 3 appointments. So we can be flexible, and we're sort of mindful that actually if somebody's kind of going away to work on things with their diabetes or to try things out, a week or fortnightly can feel quite quick. So again, it sort of varies, but on average, maybe fortnightly, probably, I would say. Thanks so much. It was a real pleasure, and thanks so much for having me.
Thank you. So Aditi Sharma is one of our senior registrar, SD7 in Northwest London, and she would be presenting today to talk about Canada EMPA of type 2 diabetes.
I'm going to use the next 20-25 minutes to give an overview of the latest NICE guidelines that are fresh off the press, published last month. And the reasons for this update has been the fact that the last guidelines were published in 2015. So this is management of type 2 diabetes in adults. And since then, there's been a lot more focus on the individualized and shared decision-making regarding HbA1c targets with the patients. But I think most importantly, since the last 2015 guideline, the key development has been the publication of these new evidence from the cardiovascular outcome trials looking at major adverse cardiovascular events, which has led to this update. So just moving on to a case, so I would need you guys to sign into the Mentimeter for this. So we've got Mr. DM, who is a 54-year-old heavy goods vehicle driver. He's got a history of ischemic heart disease, has previously had cabbage, presents with osmotic symptoms, slight polydipsia, polyuria, a bit of fatigue, no weight loss. And the GP does the observations and urinalysis and has access to a blood ketone meter, and he's slightly hypertensive, raised BMI, urinalysis shows positive 3+ glucose, but no ketones, and blood ketones of 0.1. He gets a blood workup done, which confirms an HbA1c of 73 with a normal renal function.
Okay.
So the question is, as per the NICE guidelines, what would be your initial drug of choice in this gentleman? So we've got someone who's presented with newly diagnosed type 2 diabetes, most likely. So we've got 13 out of 14 with metformin and 1 with an SGLT2 inhibitor. Okay, so then he sees his GP back within a month. In that time, the GP has titrated his metformin dose to the maximum tolerated, has started him on an ACE inhibitor for the blood pressure, which has improved. He's also, reiterated lifestyle changes, exercise, and his BMI, although still in the obese category, has come down. And he's tolerating that metformin quite well. So what would you do next? So what would your add-on drug of choice be? Would you want him to remain on the current treatment with nothing to add on because we've only just started treatment a month ago? Or would you want to start any of the other drug classes? Okay, so majority of the voters go for SGLT2 inhibitors, but we've got a couple remain on the current treatment and a couple on DPP4 inhibitor and a GLP-1 analog. Okay, so I have kind of summarized the guidelines according to the subsets that the NICE guidelines are summarized in. So individualized care, this is quite self-explanatory, but they do quite stress the idea that we should adopt an individualized approach to diabetes care tailored to the needs of the adult with type 2 diabetes, obviously taking into account all the different factors, their personal preferences, their comorbidities, the risks from polypharmacy, and the likelihood of benefiting from the long-term interventions. But one of the things that they've added to this current guideline is patient decision aid, which in order to help us agree with an HbA1c target with the patient, as well as looking at different factors that we can use to weigh up the HbA1c target. So this is what it looks like. So this is the patient decision aid. It's quite helpful, actually. It's in layman's terms, I think, quite a nice leaflet to give to the patients when we first see them or during their annual review. It kind of summarizes what an HbA1c target means, what's the importance of blood glucose and management and the effects on long-term health, and what would an HbA1c target entail in terms of the pros and cons of setting a tight target versus something that's a little bit more acceptable to a patient. And then there is this chart that is also added to these updated guidelines, where it's not an exhaustive list, but it does provide a few factors that can be discussed with the patient for them to feel part of this decision-making process of setting their own HbA1c target. So if I was to just quickly go through this, so on the left-hand side, we've got a lower HbA1c target. On the right, we have a higher HbA1c target. So factors could be that a patient could be asked is having hypos would not be a problem for me. For someone else, it could be a big problem. I'm not concerned about the possible side effects from the diabetes medicines. I'm very concerned. I'm willing to take more medicines if I need to. I do not want to take any more medicines that I'm other than the ones that I'm currently on. I do not have any health issues other than diabetes. I have lots of other health issues. And looking at my age and health overall, my quality of life in the long term is more important to me versus someone who's more focused on getting the shorter term target. Again, this is open to interpretation. There is no set target given on this chart, but it kind of can help the clinician and the patient to have a joint decision about a target. And again, this can be revisited at each clinic appointment if this needs adjusting. Education, this is again very similar to what was there in the 2015 guidelines, but I've just put there just to as an aid memoir. So it does say offer structured education to adults with type 2 diabetes and or their family members or carers at the time of the diagnosis with annual reinforcement. Dietary advice is first line. So again, an individualized dietary advice, referring them to a dietitian and looking at lifestyle modification. And if they're overweight, encouraging 5 to 10% of weight loss. And again, looking at cardiovascular risk management, smoking, lipids. There is a link on the NICE guidelines to then the bariatric surgery guidelines as well as the obesity guidelines, but I've just taken one point from that to say that if someone's got a BMI of 35 or over and they have been diagnosed with diabetes within the last 10 years, and they're part of this tier 3 service, weight loss service, then they can or they should be expedited for assessment for bariatric surgery, and those with a BMI of 30 to 34.9 should be considered for assessment of bariatric surgery. So going back to Mr. DM, he had an initial blood pressure of 156/77, and the clinician rightly started him on an ACE inhibitor. What do the latest guidelines say about the target clinic blood pressure that we should be aiming for? Okay, so less than 135/90 wins, and then we've got a bit of a spread for the others. The latest guidelines have amended the hypertension target. So the 2015 guidelines had different targets for type 2 diabetes and then type 2 diabetes with micro macrovascular complications. Just to make it, I think, easy and streamlining the targets, they have put the link for the NICE guidelines on hypertension in adults so that the targets are broadly the same for type 2 diabetes as for other people. So just as a reminder, so it's divided into age targets. So age less than 80, which is what our Mr. DM is. The target for a clinic blood pressure is less than 140/90. And for an ambulatory or a home blood pressure monitoring, it's less than 135/85. And a little bit more lenient on the targets when someone's elderly, obviously risks of falls, postural hypertension. And in terms of, although they do suggest individual HbA1c target, the cutoffs are aiming for an HbA1c of 7% for most patients, if feasible. And if the HbA1c rises to above 7.5%, so 58 millimoles per mole, then to consider reinforcing diet, lifestyle, compliance to drug treatment, supporting them to get to a 7% target and adding on the drug treatment, which is what the biggest change, which is the drug treatment choice in the current guidelines. So this is what the CDE of type 2 diabetes, where the title came from, because the latest update has looked at the clinical and the cost effectiveness evidence for SGLT2 inhibitors. So SGLT2 inhibitors with cardiovascular benefit, which is the CANA, DAPA, and the EMPA, in patients with established cardiovascular disease or at high risk of developing cardiovascular disease. And I'll come to that in the next slide. And in summary, it's recommending SGLT2 inhibitors in a much wider population than our previous NICE technology appraisals. So what do they mean by high risk of developing cardiovascular disease or established cardiovascular disease? So established, quite self-explanatory, it's someone who's had a history of coronary heart disease, cerebrovascular disease, or peripheral vascular disease. The high risk of developing cardiovascular disease, this is based on the cardiovascular risk guidelines, so using Q-risk-2 score of if it's moderate risk, which is defined as more than 10% in adults aged 40 or over, or in those under 40, because Q-risk-2 can underestimate the cardiovascular risk in that age group, then looking at other cardiovascular disease risk factors such as hypertension, dyslipidemia, smoking, obesity, positive first-degree premature cardiovascular disease, family history. So if any of those are present, then they fall under the category of high risk of developing cardiovascular disease. And then they provide this visual aid to help with considering factors to take into account when opting for your medicine choice, or changing it, or escalating it. And the rescue therapy, so anyone, again, I think this is again open to interpretation. What do you mean by rescue therapy? But if anyone's got symptomatic hypoglycemia, they do say consider insulin or a sulfonylurea until blood glucose control has been achieved. But other than that, diet and lifestyle advice, choosing treatments according to all the previous factors we discussed, and then reviewing and changing treatments according to tolerability, cost, guidelines, weight, metabolic risk, cardiorenal risk. And the first line treatment remains the good old metformin. So offer standard release metformin as the first line treatment to all patients. But the biggest change has been in patients that have established cardiovascular disease, or chronic heart failure, or they're at high risk of developing cardiovascular disease according to the Q-risk-2 score or the risk factors, then they suggest the first line to be both metformin and an SGLT2 inhibitor. Monotherapy with SGLT2 inhibitor if metformin's not tolerated or contraindicated. And the way they suggest to do this combined therapy is in a sequential way so that we can assess the tolerability to metformin. So if you remember my question, the first two Menti questions, so initial choice was, drug choice was metformin, and then escalating to an SGLT2 inhibitor after a couple of weeks. I mean, there's no timeline given in the guidelines, but as long as you are happy that they're tolerating the metformin, then to add the SGLT2 inhibitor soon after. There's been no change in the guidelines if these patients don't fall under the high cardiovascular risk profile. So again, metformin, and if metformin is contraindicated, then any one of the other drug classes can be used as first line. The SGLT2 inhibitors monotherapy has a few more strict rules, which I'll just come to. And before starting, and I think this is probably the take-home message for us, because we're going to see a change in clinical practice after these guidelines. A lot more patients, which, majority of patients with type 2 diabetes that we will see in secondary care or admitted to hospital are going to be people who've either got high risk of cardiovascular disease or are established, chronic heart failure or atherosclerotic disease, will be started on SGLT2 inhibitors. And it's important to check the increased risk of DKA, which is one of the main adverse effects of SGLT2s. So, if someone's had a previous episode of DKA, then not starting them on this. If they are unwell with intercurrent illness or are going to undergo, acute surgery or admission for something else, then consider stopping it. And if patients are on ketogenic diets or diets that are very low in carbohydrates, then either to not start SGLT2 inhibitors or having a chat with the patient to delay the start until they're back on a normal diet, just to reduce the risk of DKA. And I'm sure there are many other factors that we can think of that will need discussing with the patient in terms of reducing this risk if we can. So this is the treatment algorithm provided by the nice update. So this is how to choose the first line medicine. So I know it's quite a busy slide, but if I was to just break it down, it's the first line treatment is, again, you divide it into their cardiovascular risk, which we've already spoken about. So anyone with high risk or chronic heart failure or established risk, metformin. If standard release, if they've got GI disturbance, then modified release. And then adding on the SGLT2 inhibitor as first line after metformin as well for these patients. And obviously, if metformin is contraindicated, then SGLT2 inhibitor monotherapy for these patients. And then those that are not at high risk of cardiovascular disease, metformin, and then any one of the others if metformin is contraindicated. An SGLT2 inhibitor can be used as a monotherapy in this subgroup of patients that are not at high cardiovascular disease risk, but they have to fulfill quite a lot of other criteria to be able to get that medication, which is they can't tolerate metformin, whom diet and exercise doesn't provide adequate glycemic control, and for whom sulfonylurea or a pioglitazone would not be appropriate, and you're actually thinking of starting them on a DPP4 inhibitor, then that's the time you can think of giving them an SGLT2 inhibitor. And any one of the others can be added as dual therapy. And again, a bit more asterisk is for the SGLT2 inhibitor, a few more things that you need to consider before they can be used as dual therapy for patients who are not high risk of cardiovascular disease. So going back to our Mr. DM, he's come back for an annual review now, and he's now on triple therapy. So he's on your SGLT2 inhibitor, empagliflozin. He's on metformin 1 gram BD. He's on maximum dose of gliclazide. His ramipril has been up titrated. His repeat HbA1c is 69, so still suboptimal. He is doing a good job of checking his blood sugars, and they are above target for him. He's obese, so he's got a BMI of 31, and his blood pressure is well controlled within the guideline target with the ramipril 10 milligrams. So going back to Mentimeter, what would you do next? 10 out of 14 would like to start a GLP-1 analog. So what do the NICE guidelines say about triple therapy? So if dual therapy with metformin and another oral drug doesn't continue to control the HbA1c to the individually agreed HbA1c target, then further intervention could be either one of the 4 other subgroup drug classes, or its insulin could also be started at this point. So this is another visual aid included in the guidelines, and this is how to choose further medicines. So again, they would like us to risk profile the patient according to their cardiovascular risk. And at any point, if the cardiovascular risk status changes, that is, they've developed chronic heart failure or established cardiovascular disease, or if they've now had their Q risk 2 score up to 10% or higher, then we could switch or add an SGLT2 inhibitor. Otherwise, either one of the drug classes could be used. The GLP-1, this was interesting because there hasn't been much of a change in the recommendation of the GLP-1 analogs in the current latest guidelines. And what they state is that if triple therapy with metformin and 2 other oral drugs is not effective, such as our Mr. DM, then consider switching one drug to a GLP-1 analog. If they've got a BMI of 35 or higher and have got a obesity-associated medical problem or psychological problem, or if they've got a BMI less than 35, but for whom an insulin therapy would have occupational implications, or weight loss would benefit one of the other obesity-related comorbidities. So I agree with the GLP-1 as the answer to the last question, because he does have a BMI of less than 35. He's been on triple therapy. And you could argue that insulin therapy for this chap who's a heavy goods vehicle driver who's, HbA1c of 69, you could try, and he's overweight, obese, and it would help his other, comorbidities such as blood pressure, then maybe a GLP-1 analog is more preferential compared to the other options, including insulin. And one of the SE questions that can sometimes come up is, assessing the GLP-1, when do you continue it? What is the criteria? So what the guidelines recommend is that if there's a reduction of at least 11 millimoles per mole in HbA1c, which was equivalent to 1% in old money, and weight loss of at least 3% of their initial body weight in 6 months, then the GLP-1 analog can continue. Otherwise, you should reassess about either stopping it or changing it. Managing complications, the one that I just wanted to bring up that is a bit of a change is about CKD. So obviously, since the 2015 guidelines, there's been a lot of evidence about, within RCTs that have shown that SGLT2 inhibitors reduce the risk of CKD progression, mortality, and cardiovascular events in patients with type 2 diabetes and CKD. So the guidelines do state that patients who've got type 2 diabetes and CKD and are already on ACE or ARB should be offered or considered an SGLT2 inhibitor if their urine ACR, so it should be offered it if the urine ACR is above 30, or consider it if it's between 3 to 30. And I believe there isn't any specific evidence looking at the effectiveness of SGLT2 inhibitors for patients who've got a baseline urine ACR of less than 3 milligrams per millimole. And obviously, you'd need to consider what the eGFR of that patient is in terms of the CKD, because there are different thresholds for the different SGLT2 inhibitors where they can be initiated or the dose needs to be adjusted. Just coming towards the end. So again, I'm not going to go into this, but just to be aware that this is quite helpful. What they've done is they've provided a summary of the different medications in terms of first line and further along the dual triple therapy and what their contraindications are, what the effect on weight might be, the risk of hypoglycemia, and what to do in terms of renal or hepatic impairment. And lastly, the main, thing to be aware of is that with the change in the treatment algorithm, this is going to change clinical practice. And I think SGLT2 inhibitors are relatively new drugs, and clinical experience with them is low, especially in primary care. But I think this is going to change with this latest guidelines. We're going to see an increased use of this CDE in type 2 diabetes. There's going to be a lot higher risk profiling, although we were doing Q-risk2 scores for lipids for type 2 diabetes. But obviously, as it's going to now change your first line therapy, then a lot of these patients are going to be assessed on their cardiovascular risk profile or their CKD profile. And I guess more from our perspective as registrars and acute medics, we probably will see a lot more of DKA coming through the door. And it's being aware that SGLT2 inhibitors cause euglycemic DKA. And there may be some patients that are misdiagnosed as type 2, but maybe type 1, who maybe started on these SGLT2 inhibitors. And maybe considering, these patients being more aware, being informed about the sick day rules, what should they do when they get admitted to hospital, when they're on SGLT2, when they're being admitted for, an elective procedure, surgical procedure. Do we start giving ketone meters, or should GPs be giving ketone meters to these patients who will be started on SGLT2 inhibitors? And lastly, about the GLP-1 analogs. I think because NICE is a lot about clinical, so not just clinical effectiveness, but cost effectiveness, the GLP-1s were not found to be cost effective according to their economic modeling for cardiovascular benefits. So they have stuck with them within the third line therapy. The only change in the guidelines with GLP-1 has been the fact that they have now, initially the previous guidelines said, add a GLP-1 if someone's on metformin, sulfonylurea, and another medication. But now they've just said if someone's on triple therapy and fulfills that BMI target and comorbidities, then to consider a GLP-1 analog. They haven't, the latest guidelines, looked at the clinical and cost effectiveness for GLP-1 to control blood glucose levels, and they state that this was beyond the scope of this latest guidelines. And as we are aware, the obesity guidelines are recommending GLP-1 analogs for patients who've got a BMI above 35 and have got something like pre-diabetes or dyslipidemia or hypertension. So I guess there's going to be a little bit of difference in the obesity guidelines with GLP-1 versus this type 2 diabetes, because we may have someone who's obese and is pre-diabetic, might be on a GLP-1 analog, but maybe when they become diabetic, then they would not fulfill the criteria to be on a GLP-1 according to the NICE guidelines. That's it. Thank you.
Thank you, Aditi. That was a fantastic update. We have a question on the chat, whether there is any evidence or guidance for switching between different types of GLP-1s.
No, there isn't. There isn't anything specific about switching between, but based on the obesity guidelines, obviously, and based on the latest evidence with GLP-1, we know that different forms of GLP-1 analogs have, different outcomes in terms of weight loss, HbA1c, for example, oral semaglutide versus injectable form, and same between liraglutide and semaglutide. So there are differences in the outcomes between the GLP-1 analogs, but nothing in the guidelines specific to patients with type 2 diabetes that they've recommended.
Thank you. Another question is, any NICE guidance on the use of SGLT2 in non-diabetes patient in cardiology?
Yeah, very good question. So there has been a couple of NICE technology appraisals that have got published, one this month, 9th of March, which is recommending DAPA, specifically dapagliflozin, in patients with CKD and macroalbuminuria, with or without diabetes. So it's got a specific different cutoff. So I think the eGFR needs to be between 25 to 75, and the urine ACR needs to be, it's a random number, above 24.5 if they don't have diabetes, and that can be used in CKD as long as they're on their other optimum CKD therapy. And same with both DAPA and EMPA. There are NICE technology appraisals for use of these in heart failure with reduced ejection fraction in patients independent of their type 2 diabetes.
So firstly, thank you very much for the invitation, Harriet, Kavita, and Prof. Niran. So I've been asked to talk about the diabetic foot and optimizing its management. So I'm just going to start out with some background. So why is diabetic foot disease relevant? And then I'm going to concentrate mainly on the diagnosis and treatment of diabetic foot infection, because that's really what you'll get involved with as diabetes specialist registrars, both for patients who are admitted on the acute medical on call, as diabetic foot disease is probably the commonest diabetes-related reason for an emergency admission to hospital now. It's more common than DKA, HHS, and hypoglycemia. And it's also something that you will come across when you're doing multidisciplinary diabetes foot clinics. And so, well, what are the costs? You've got the human cost, and that's both the morbidity and the impact on the quality of life, as well as the mortality and the financial cost. So I'm just going to make this interactive and start with a couple of multiple choice questions. So if you could go on to Mentimeter then, please. and vote. So what is the 5-year mortality for a person with diabetes who has had a history of foot ulcers and a limb amputation? So this is a major amputation where it's either above knee, below knee, or through knee.
That's a matter. So 8 people have answered 50%, 7 have answered 80%, and then 1 each for 20 and 30%.
Okay, so the correct answer is 80%. So the correct answer is 80%. And so, I mean, this mortality is worse than most cancers, including colonic, prostate, and breast cancer. Definitely worse than something like thyroid cancer. And these patients tend to all die from cardiovascular disease. Then looking at the quality of life for a patient with a diabetic foot ulcer is actually worse than someone who's got COPD or someone who's on dialysis. So it has a profound impact on their quality of life. So the next question, what sum of money does the NHS spend annually on the treatment of diabetic foot disease? Is it 1 million, 100 million, 1 billion, 10 billion, or 150 billion?
About 6 people saying it's 100 million. We've actually got 5 people saying 10 billion. And then a few scattered. There's 1 person who thinks it's 150 billion.
So the correct answer is 1 billion. So 10 billion, these figures are from 2014 and 2015. 10 billion at that time was the annual diabetes budget, and 150 billion was the annual budget for the whole of the NHS. So 1 in 150 pounds spent on the NHS is spent on diabetic foot disease. So that's a large sum of money. And 2/3 of this expenditure is on outpatient treatment in community, primary and outpatient care for the treatment of foot ulceration. 1/3 is for inpatients who are admitted with diabetic foot disease, and also those that require amputation. And this has increased from 650 million just in the 5 years between the figures that were last done in 2011 and 2012. So it's increased by 350 million a year over a 4-year period, and probably if you repeat it now, it'll have gone up even more. So the final question for Mentimeter is, do you currently see or have you previously seen patients in a multidisciplinary diabetic foot clinic? Okay, good. Can you still see my slides?
3/4 actually people who were seeing.
Right, okay, excellent. So multidisciplinary care is very important. This document by Diabetes UK, published in 2013, showed that there's currently 185 amputations a week in England in patients with diabetes. About 80% of these are caused by a foot attack, which is a foot ulcer or infection failing to heal. And when these people are seen by a specialist multidisciplinary team, this has been shown to promote faster healing, fewer amputations, so it saves lives and it saves money. So for healing of an infected diabetic foot ulcer, you require within the multidisciplinary setting to have appropriate wound care. That's mainly done by our podiatrists. So this is things like sharp debridement and dressings, appropriate antibiotics if the foot ulcer is infected. And I'll talk about how to assess for infection and then which antibiotics you should treat with. Optimization of blood supply, that's involvement of our vascular surgeons. Appropriate offloading of pressure, that's usually done through help with using insoles, orthotic devices. So we have an orthotist as part of our multidisciplinary foot care team. We also have a foot and ankle surgeon, and good metabolic control. So looking at the diabetes control. And these patients, the most commonest cause of death is not sepsis from the foot infection, it's cardiovascular death. So remember also to address cardiovascular risk factors, as Aditi has outlined with the discussion of the NICE guidance, so blood pressure, lipids, smoking status, etc. So I'm just going to talk about the diagnosis and treatment of foot infection. I'm going to talk about how to diagnose a diabetic foot infection and grade the severity, how to select appropriate empirical antibiotic therapy, talk about antibiotic guidelines using the guidelines we have at London Northwest Healthcare University Trust as an example, and then just talk a little bit about the diagnosis and treatment of diabetic foot osteomyelitis, and just an algorithm for a patient with diabetes and a suspected foot care infection. So I'm going to refer to the International Working Group for the Diabetic Foot Guidelines, which are updated every 2 years. So the latest version is the 2019 versions, though there will be very shortly the 2021 guidelines will be published, but they're available on the IWGDF website. So managing diabetic foot infections requires careful attention to a number of factors. So proper diagnosis of an infection, obtaining appropriate specimens for culture before starting any antibiotic therapy, thoughtfully selecting which is the most appropriate antimicrobial, thinking about antimicrobial stewardship, determining when surgical interventions are necessary, and providing additional wound and patient care. So looking at appropriate dressings, offloading, and looking at the other patient factors and cardiovascular risk factors, and a systematic evidence-based approach to managing diabetic foot infections most probably improves outcomes. Just starting with some definitions. Now, this sounds like really common sense, but you'll be surprised how often this is not done. And if you were to actually just take a swab of every single patient who attended with a diabetic foot infection, and if that swab grew antimicrobials, then you would end up, and you treated all of those, you'd end up treating a lot of patients who just have skin conolizers, and they're not actually causing infection. So actually, you know, you only have infection if you've got invasion and multiplication of microorganisms in the tissue that is inducing a host inflammatory response. So you need to actually assess things clinically, looking for signs of acute inflammation. And then this often leads to tissue destruction. And a diabetic foot infection is defined clinically as the presence or manifestations of that inflammatory response in any tissue below the malleoli in a person with diabetes. So the first recommendation is to diagnose a soft tissue diabetic foot infection clinically, and then secondly, to assess the severity of any diabetic foot infection using the Infectious Diseases Society of America, or the International Working Group on the Diabetic Foot Classification Scheme. And I'm just going to go through that and how you do that. So this is an example of a patient who's got a plantar ulcer on their left foot over a pressure point, the first metatarsal head. You can see that there's healthy pink granulation tissue in the base. There's no acute signs of infection. There's no exudate. There's margins of the ulcer are well demarcated. There's no surrounding cellulitis. There's no warmth or erythema when you examine this patient. And so I would say that is not clinically infected, and that's grade 1. Now, this is a patient of mine who has a Sharco Arthropathy. He was in a crow boot and he's got a hallux valgus deformity here. and he developed an ulcer overlying this due to friction from between the inside of his boots and his foot. So you can see here that there is a little bit of erythema around the wound. It extends just beyond the wound. It's more than 0.5 centimeters, but does not extend beyond 2 centimeters. The ulcer itself is reasonably superficial. There's possibly a little bit of exudate here. It doesn't probe to bone. And as I said, there's just a little bit of erythema around it. It felt a little bit warm, but this doesn't extend beyond 2 centimeters beyond the margins of the wound. There's quite a lot of healthy pink granulation tissue here. So I would describe this as mild infection or infection grade 2. Then this is someone else who developed an ulcer on the apex of their right great toe. You can see here there's considerable soft tissue swelling, and when our podiatrist took a metal sterile probe and probed the ulcer, you could probe to bone, and that feels very firm when you probe with a sterile metal probe. So clinically, there's a very high risk of osteomyelitis here because they've got a sausage deformity of their toe. They've got a lot of soft tissue swelling, and they also probe to bone. That means each of these on its own gives at least a 50% chance of osteomyelitis. And then we went on to do a plain X-ray, and you can see the soft tissue swelling here on the X-ray. You can also see that there's a breach in the cortex at the tip of the distal phalanx of the right first toe. So there's evidence of osteomyelitis. So if you've got infection that's deeper than the skin and subcutaneous tissues, so if you've got osteomyelitis or you've got exposed tendon or exposed bone, then that's defined as moderate infection. And this is a gentleman who actually came in on the acute medical take a few years ago. He's an Asian gentleman, he was in his early 50s. He didn't have a formal diagnosis of diabetes at the time. He fell asleep with his foot on a radiator, woke up a couple of hours later with a blister on the sole of his foot, ignored this for 6 weeks, then came into hospital, and on examination, he was febrile. He had a temperature of 38.5 degrees. He had a neutrophil leukocytosis. He was neuropathic. He had good foot pulses. He had a capillary glucose of 25, so he had undiagnosed diabetes. He was presented with fevers and rigors. So he was very unwell. He needed admission to hospital. He had evidence of a systemic inflammatory response syndrome. And so this would be classified as severe infection, and severe infection usually requires hospitalization and IV antibiotics. When we did his plain X-ray, we could see that he had evidence of gas gangrene. So these dark areas within the soft tissues are pockets of gas. So he's got gas-forming bacteria, which were causing very severe metabolizing the glucose in his bloodstream and causing very severe infection. I spoke to our vascular surgeon straight away, and then within 24 hours of being seen by a vascular surgeon, he'd had a debridement in theatre and amputation of his second, third, and fourth toes. He was very lucky to not lose his foot, but actually over the years, he neglected his diabetes. He ended up on dialysis about 4 years later. And then following that, a year after that, he had a STEMI and unfortunately died from that. So as I highlighted, these patients are a very high risk of cardiovascular disease, and cardiovascular disease is the commonest cause of death in these patients. So the characteristics that would suggest a more severe diabetic foot ulcer are listed here. So as I said, if there's extensive infection, extensive cellulitis, or the wound is very, very deep with exposed tendons, muscle, joint, or bone, if they've got any crepitus suggesting gas, if they've got necrosis or gangrene, if they present with fevers, rigors, hypotension, features of sepsis, if they've got very high inflammatory markers, or they've got, if they're immunosuppressed, or they have failure of their standard antibiotic treatment, all of these would suggest a severe infection. So the reason that it's important to categorize the seriousness of the infection as mild, moderate, or severe is that the types of organisms you need to cover differ depending on the severity of the infection. So, that's, as I said, and for osteomyelitis, you need a longer duration of antibiotics, usually 4 to 6 weeks. So you should start with empirical treatment initially and cover the most common likely organisms. And I'll just go through in the next slide what they're likely to be depending on the severity of the infection. You should consider local antibiotic resistance, and the experts who know about this are a microbiologist, so speak to your local microbiologist within your hospital. The other considerations are, as a patient allergic to anything. So a lot of patients might say they're allergic to antibiotics such as penicillin, but a lot of them won't have a true allergy. It'll be more that they have side effects due to this. And in our trust, we're very lucky in that we have an infectious diseases team who runs a clinic and does penicillin allergy testing. And this has helped us out in a number of occasions where we've then been able to give people penicillin because we know that they're not allergic to it, but that they've just had some side effects, such as a rash or a mild rash or some GI symptoms. But it's certainly been very helpful to do that. And then also patient choice and compliance. So if I wanted to cover, if I had someone who's allergic to penicillin and I want to cover gram-positive cocci, such as Staphylococcus, and the patient's got osteomyelitis, and I want an antibiotic that's got good penetration to bone, I might choose doxycycline or clindamycin. For clindamycin, they might have to take 3 capsules 4 times a day. And with doxycycline, it might be 2 capsules once a day. So if the patient doesn't like taking lots of medications, I would go for the doxycycline there. And then you've got to consider the setting, whether it's hospital, home, IV antibiotics, and the home IV antibiotics depends on what sort of level of OPAT service, outpatient parenteral antibiotic service, you have available in your borough. So going on to empirical treatment, for mild infection in someone who's antibiotic naive and lives in a temperate climate such as the UK, Staph aureus and streptococci are the commonest organisms. And Staph is the most common of these. So if someone's antibiotic naive, you could, for example, give them something like flucloxacillin or comoxiclav if it was a mild infection. If it's a moderate to severe infection, or in a tropical or subtropical climate, or they've had recent or recurrent courses of antibiotics, or they've got evidence of ischemia, you have to think about the gram-positives, but also gram-negative organisms, and if they've got evidence of ischemia, obligate anaerobes as well. And then it's very, very important as part of antimicrobial stewardship to reconsider your antibiotics based on the clinical response and sensitivity of the cultures that you send. So just a little word on Pseudomonas. Coverage is not usually necessary in places like the UK, but you should consider coverage if the patient lives in a tropical or subtropical climate, or if they've previously had Pseudomonas aeruginosa isolated from microbiology samples. Now, moving on to the route of administration, oral versus intravenous. This is a very nice review in the New England Journal of Medicine a couple of years ago. And from that, this recommendation is that you should administer antibiotic therapy initially by the parenteral route to any patient who's got a severe diabetic foot infection. So these are the ones that you'll see who get admitted on the acute medical take or get admitted from diabetic foot clinic. But actually, you should be able to switch to oral therapy within 5 to 7 days if the patient is clinically improving, has got no contraindications to oral therapy, and there's an appropriate oral agent available. And then there is also some evidence, that some of these patients, if they don't have a severe infection, but they require intravenous antibiotics because either they're allergic to the oral agents available, or they've grown bacteria that are resistant to any oral antibiotic, then actually you can avoid admission if you've got a well set up OPAT service. Now, the provision for OPAT services just varies throughout the whole of northwest London, but actually this paper just shows you what the good practice recommendations for an OPAT service is. And one of the co-authors is Mark Gilchrist, who I understand is one of the microbiologists at Imperial. So it's worth having a read of this and just seeing how your OPAT service locally compares with these best practice guidelines. Just an example of antimicrobial guidelines. These are the ones that our trust, London Northwest University Healthcare, and they're also available on an app which we use. So you can download them onto your smartphone, but each organization, the ones you work at, will have their own antimicrobial guidelines, so it's worth having a look at them. So if you've got someone with mild infection, as I said, often flucloxacillin or coamoxiclav are sufficient because you're covering predominantly Staphylococcus and Streptococcus. Again, you should review once your microbiology results are available. The duration should be 7 to 14 days for soft tissue infections. If you've got penicillin allergy, then you should go for something like doxycycline or clindamycin. Again, review once your microbiology results are available, and start off with a duration of 7 to 14 days. That's usually sufficient for soft tissue infections. If you've got a moderate infection, you might need a slightly longer duration of antibiotics, between 2 and 4 weeks, 6 if you've got osteomyelitis. Again, once again, review things once you've got your microbiology available. If you have got osteomyelitis, you need an antibiotic who's got good penetration into bone, and all of these, doxycycline, ciprofloxacin, clindamycin, all have good penetration into bone. And then if you've got severe infection, these are the patients you'll see as an inpatient. So on our antibiotic guidelines, the flucloxacillin will cover your gram-positives. Ceftazidime has some gram-positive and also gram-negative cover, and then metronidazole covers anaerobes. Once again, it's important to take your microbiology samples before the patient is started on antibiotics, and then review things as soon as possible once you've got the results available. Often we'll discuss the more complex patients in our multidisciplinary diabetic foot MDT, which our microbiologists attend. The factors that suggest you need to hospitalize the patient, this is important when you're the medical registrar on take and you need to decide whether the patient needs to come in. If they've got a severe infection, they need admission. If they've got metabolic or hemodynamic instability, so if they've got very high blood sugars, if they are hypotensive, then they need to come in. Obviously, usually if intravenous antibiotic therapy is required, they'll need to come in unless you can arrange it rapidly through OPAT. If they've got ischemia or they need a surgical debridement or revascularization procedure, they'll need to come in. If they need very frequent or complex dressing changes or daily changes of dressings, they'll need to come in. So what's the best microbiology sample to take? Is it a wound swab or is it a tissue specimen? So the recommendation is that you should take an appropriate specimen for culture. For a soft tissue foot infection, obtain a deep tissue specimen by aseptically collecting the specimen by curettage or biopsy from the ulcer. This is usually done by our podiatrists. Obviously, if the patient comes in over the weekend, you haven't got that facility available, so it's probably better to try and take a deep swab from deep in the ulcer base after irrigating it with normal saline. So this is the Codify study, which compared wound swabs with deep tissue specimens, and it basically showed that that the samples from deep tissue specimens were more informative. So fewer deep tissue specimens had no bacteria, and more clinicians, when blinded, would change antibiotic therapy based on the results of deep tissue specimens than the swabs. So we're involved as one of the sites investigating on the Codify 2 study, which is doing further work and looking at special molecular biology techniques on both wound swabs and deep tissue specimens. So that's a study in progress at the moment and will probably be going on for the next couple of years. Now, what do you do with osteomyelitis? So firstly, how do you make the diagnosis? In a person with diabetes and suspected osteomyelitis, they recommend a combination of the probe to bone test, which the podiatrist can do with a sterile metal probe, the ESR. So ESR goes up in osteomyelitis, often to very, very high levels, often above 50 or even above 100, and then falls with treatment. And plain x-rays are the initial studies to diagnose osteomyelitis. So initially, plain x-ray can be fairly insensitive because you need to have lost 30 to 40% of your bone to pick up osteomyelitis on a plain x-ray. But if you do serial x-rays every couple of weeks, you will pick it up. Now, if you're in doubt, despite doing the probe to bone test, plain x-rays and an ESR, then you can go on to do further advanced imaging such as MRI scan, but you don't need to do it if it's obvious on x-ray. So really the indications for an MRI scan is if you are worried about the patient might have an abscess in their foot, or it's really not clear from the initial tests you've done whether or not there's osteomyelitis present. And this is a nice little review on diagnosing diabetic foot osteomyelitis, which is published in Diabetes Metabolism Research and Reviews. And the nice guidance says, think about osteomyelitis, particularly if the patient has a deep foot wound or a chronic foot wound. This is just an example of one of our patients who developed osteomyelitis. You can see the sausage toe deformity. You can see evidence of surrounding cellulitis of his foot. He actually presented with a bacteremia and back pain, and he'd had sort of spread of the organisms through the bloodstream to his spine, and he developed spondylodiscitis as well. So the case report was published in British Journal of Diabetes. This is an example of his plain X-ray, which shows complete destruction of the bone, the proximal phalanx of his great toe. There's also a sequestrum of bone here with no blood supply. So that's pretty clear-cut osteomyelitis. This is just an enlargement. So this is a sequestrum of bone with no blood supply. You've completely lost your cortex here, and you've got reabsorption of bone here. Now, would you use antibiotics or surgery? So for forefoot osteomyelitis involving the toes, you can have an up to 90% success rate with antibiotic treatment alone. So the majority of that is treated with antibiotics, and amputations only if the antibiotic treatment fails or the patient is unable to tolerate it. The prognosis with antibiotics for hindfoot or heel osteomyelitis seems to be a lot worse. But sometimes surgery shouldn't be counted as a failure of treatment. It should be considered as a part of treatment for some patients. Now, talking about the duration of antibiotics for osteomyelitis, there's no significant difference when patients have been randomized to a 6-week course of treatment or 12 weeks course of treatment. So really, if you haven't treated the osteomyelitis successfully after 6 weeks, you have to consider, have you addressed all the other risk factors? Have you offloaded the patient adequately? Have you optimized their blood supply? Have you optimized their glycemic control? And have you used appropriate dressings and wound management? So this just goes through features characteristic of osteomyelitis on plain X-rays. I talked about some of these, but the loss of the bone cortex, radiolucency suggesting demineralization, bone sclerosis tends to suggest healing of the phase of osteomyelitis. If you get an abnormal soft tissue density in the subcutaneous fat or sometimes gas, which extends from the ulcer deeper down, then that might suggest a deeper ulcer or sinus. And then if you can see sequestrum, as I mentioned, so they're the commonest things that you'll see on X-ray. This is just finally a management algorithm for a patient with diabetes and a suspected foot infection. I know this is a very busy slide, but I've just expanded it here. So you need to assess the patient. Do they have neuropathy, reduced sensation? That increases your risk of ulceration at least 5 to 8-fold compared with a patient with diabetes who doesn't have neuropathy. Do they have adequate foot pulses? If you can't palpate the foot pulses, feel for the popliteal pulse. If you can't feel that, feel for the femoral pulse. Our podiatrists have handheld Doppler devices, and they can look at the signals and tell you if they're monophasic, biphasic, or triphasic. What are the medical psychosocial comorbidities? You've all heard a talk from a diabetes clinical psychologist, and our foot patients have a lot of psychosocial needs. You should assess the wound characteristics, and our podiatrist will cleanse, debride, and probe the wound, and then you should clinically assess them. And are there signs of infection and inflammation? Optimize glucose and metabolic status, obtain your microbiological specimens, and then determine whether or not they need to see a surgeon. If it's clinically infected, classify the severity. The severe infections, these are all going to need to be admitted. Mild to moderate infections can be managed as an outpatient. And really, the thing is, they need to be regularly reassessed. And then if you're not winning, they're the patients that might need to be admitted to hospital. But you also have to look at all the other factors and check that you're addressing those. For patients who are hospitalized, you need to attend to their metabolic needs. If they're febrile, you should obtain blood cultures. They might need review by a surgeon. They might need debridement. They might need revascularization. They might need amputation. Start off with a broad spectrum parenteral antibiotic regimen. Make sure you do adequate and appropriate wound care, the dressings and debridement and offloading. Reassess clinically at least once a day. If things are improving, you can step down to orals. If things are not improving, you need to reassess the need for surgical intervention or revascularization or amputation. Once you've got your microbiology specimens, then you might be able to step down antibiotics. If things are not, if you're not winning with your empirical antibiotics, then you need to discuss with microbiology whether or not you need to broaden the spectrum or change the antibiotics. So just to conclude, diabetic foot disease, I hope you can now understand, is associated with significant morbidity and mortality and cost, both personal and financial, to the NHS. 80% of diabetic-related amputations are preceded by a diabetic foot ulcer and hence are potentially preventable with good multidisciplinary care. And then SBR, you will commonly treat patients with diabetic foot infections, and I hope that this presentation will help you develop a systematic evidence-based approach. Thank you very much for your attention. Happy to take any questions.
Thank you very much, Dr. Mehta, for such a structured overview. Really interesting to learn about the Codify 2 study. I think that one of the things that I know that I find sometimes challenging in patients who don't have overt signs of infection is whether patients do need to start on antibiotics, or sometimes indeed you're asked to stop antibiotics. Can I just ask quickly, how much weight do you put on whether the ulcer probes the bone in your own clinical assessment?
So I mean, I think it should be something as part of the standard assessment when we see these patients in the foot clinic. I always sort of make a note of how deep the ulcer is, and you know, if it's probing to bone, then you'll definitely want to get a plain X-ray. Though an X-ray that is normal does not exclude osteomyelitis. So if someone's got a positive probe to bone test, the clinical probability of osteomyelitis is 50% or more. If they have soft tissue swelling of the digit or a sausage toe, then the clinical probability of osteomyelitis is 50% or more. If they've got both of those, then you know, more than likely they will have osteomyelitis.
Thank you. Does anyone else have any other questions? Okay, thank you very much, Dr. Mehta.
Thank you for the invitation.
Thank you. Okay, so next it's a pleasure to introduce Dr. Sufyan Hussain. Dr. Hussain was a North West Times trainee and he's currently a consultant diabetologist at Guy's and St Thomas's Hospital and an honorary clinical lecturer at King's College. He has a specialist interest in the application of diabetes technology, and today is going to talk to us about the utility of technology whilst fasting in those with type 1 diabetes. So thank you very much, Dr. Hussain, and I'll hand over to you.
Thanks a lot to Prof. Miran and Harriet for inviting me. Can you hear me okay, firstly? Good. And you can see the slides, I take it?
Yes.
Thanks a lot. Brilliant. As Harriet mentioned, I'm a consultant diabetologist at Guy's and St Thomas's and honorary senior clinical lecturer at King's College London. And I'll be talking about fasting in type 1 diabetes and the utility of technology. Firstly, these are my disclosures, and I've got nothing industry related to disclose, and slides and views expressed on my own. And what I'll be doing is just giving you a little bit of a run through of Ramadan means, very briefly, because time is short, and then discussing probably for the first third of why fasting with type 1 diabetes can be high risk, and which relates to the current and previous guidance as well. Then spending the next 2/3 discussing how technology can make it actually safer and what we need to do to revisit the risk stratification. And then towards the end, we'll be discussing some of the novel therapies around hybrid, about some of the research that we've been doing around the novel therapies. So firstly, Ramadan, and this may be familiar to some of you who are working in Northwest London, where there's a high prevalence of people from backgrounds who are undertaking fasting. And indeed, it's not just Ramadan, it's also a number of other religions that have fasting as an important spiritual aspect. And certainly now more and more, we're seeing intermittent fasting being practiced for metabolic health benefits. For Ramadan, what does it mean? Well, it will be happening in approximately 2 weeks' time. It's one of the longest periods of religious fasting from dawn till dusk for a whole month. And it involves abstinence from eating, drinking, taking any oral or inhaled medications from sunrise to sunset, and also abstinence from smoking as well. And what it means for diabetes, well, firstly, more than 50 million people with diabetes fast during Ramadan. This is based on data from 2010, more than a decade ago, and obviously that is very likely to have increased significantly now. First and foremost, just to make the statement, there's no obligation to fast if you have health risks. There's a lot of detailed medical guidance that exists for a variety of health conditions, including diabetes. And if you want that information, there's a great resource from the British Islamic Medical Association covering a number of conditions in relation to this. There are a number of other exclusions, such as traveling, being old in age, mental handicap, pregnancy or menstruation as well. In relation to diabetes, there's risk stratification, which you can see on the British IMA, and I'll be discussing the more specific aspects in relation to type 1 diabetes shortly. But indeed, choosing to fast is a personal decision, much like choosing to run a marathon is a personal decision. It's no obligation for anyone to run it with type 1 diabetes, but there might be people who choose to do it, and our role is to help ensure that it's done safely and some of the sense checks, some of the understanding in relation to it. So just to discuss the pathophysiology of fasting, and this may be things that are very familiar to you all, but I think it's important just to kind of hone in on some of the physiology. When we talk about some of the specifics, it'll become much clearer. Firstly, for anyone undertaking fasting, it involves eating a meal in the morning, and that will, in the case of Ramadan fasts, and that obviously it has a high, a calorie intake is going in, which you have to match with insulin. In a normal person, the insulin is secreted in a manner that makes sure that the glucose doesn't go low, doesn't go high, and as a fast ensues, insulin is then switched off in the background, and that allows glucagon's effects and gluconeogenesis to occur. And indeed, as the fast goes on for periods that may be as long as 15 or 16 hours in the Northern Hemisphere countries, nowadays, I mean, the UK a few years back, it was about 17 to 18 hours. As the fast goes on, cortisol secretion also goes up. And during that time, glycogen stores are used up and they get eventually depleted, and therefore you get ketogenesis or ketone bodies forming as a result of it. So so that's what happens in a normal person. And then obviously as the fast is broken, it usually involves a fairly big meal, and culturally that's what happens these days. It's the meal can be quite calorie rich and carb rich as well. And then again, that influx of carbs and calories in a normal person will be matched with the appropriate amount of insulin. And that cycle continues for a month. So what would happen in type 1 diabetes? Well, you may not get the appropriate insulin adjustments to the food in the morning, and that might leave you high or low with the risks, therefore, thereafter. And as fasting goes on, you've got background insulin, which means that glucagon's efficacy is reduced, or it may not be released appropriately in this situation, meaning that glucose levels may drop. And that requires adjustments, obviously, to maintain it. And then, of course, when you break your fasts, certainly when you've got a lot of glucagon on board and cortisol released, and you can imagine a high carb intake, that needs to be matched with an appropriate amount of insulin. Otherwise, very high sugar levels can result. So that's in a nutshell of the physiology of fasting and why it's such a challenge in type 1 diabetes, because you obviously don't have any background insulin to rely upon. So what are some of the risks associated with it? Well, I'll discuss some of the observational work, and that is, so very much as we would think, hypoglycemia is a big risk, and hyperglycemia and diabetic ketoacidosis, especially in those who may end up omitting insulin because they're thinking, well, I'm not eating, so I might as well not give insulin. And then obviously for chronically high sugars, along with dehydration, that can lead to situations such as thrombosis or indeed even ischemic heart disease. And those are some of the risks that we worry about when in relation to fasts. The epidemiological studies were mostly done in the early 2000s. And what that showed, and this is looking at multinational data, so looking at a number of different countries, most of them in the subcontinent, some in the Middle East, as well as the UK and the US. Obviously, at that stage in 2004, analog insulins weren't around. Daphne wasn't really mainstream, and technology wasn't really available. And indeed, when you looked at developing countries, again, the sort of understanding of how to dose adjust and what sort of insulins we used was very primitive. So clearly with that, there was a very significant increased hypoglycemia risk during the fasts. And indeed, hyperglycemia was also increased. I won't have time to detail, but subsequently we've also had a lot of developments in diabetes with Daphne and analogs, to name some, and that's certainly reduced the DKA risk and severe hyperglycemia risks. But the hypoglycemia risks, the low sugar risk, are indeed some things that we do still worry about in relation to fasts. So what does that mean for our current approaches for risk stratifying people? And what advice do we give them? I won't have, again, too much time to detail this, but there are references in the talk that you can always look at for more details. But in relation to type 1 diabetes, and I would say I'm guilty of putting that in the high risk category, and I'll discuss why I feel I'm guilty later, but even well-controlled diabetes has been placed in that, and that's really derived from the epidemiological data based on 2004. And certainly even the international guidelines that have been published very recently, again, I'm sorry, it's quite a detailed table, but that's how they've decided to present this. But that again puts people with type 1 at very high risk. So it's a scoring system. If you're above 6, you're high risk. Anyone with type 1 will score 1. And then if you decide, if like most people with type 1, you have multiple weekly hypoglycemia, you're scoring 3.5 on top of that. And if you're on multiple daily injections or even basal bolus or insulin pumps, which is most likely going to be the case in the UK, that's going to score you around the 6. You're going to be scoring 6 already. So you can imagine most people with type 1 will fall into a high risk category, even if you use the more recent guidance. So that's, and so far in terms of therapy adjustments, a very noddy approach has been advising reducing the basal dose to 50 to 30% and taking your bolus dose as usual. So reducing the basal to avoid a late afternoon or early evening hypoglycemia, and reducing it by 15 to 30% and using your usual strategy of bolus. The other recommendations that are given, and some of them are very obvious, in that break your fast if your sugars are low, or indeed if your sugars are high. And certainly for driving, there are other considerations as well, which we've published. But that's a current, I guess, more and previous guidance. And despite this, 43% with people with type 1 diabetes still fast. So obviously shows that, there is a personal decision. Despite it being considered as a high-risk situation, it still means a large number of people with type 1 diabetes still fast. And why is that? Well, it's important possibly for their spiritual health, or indeed it could also be that health literacy might need to be improved to enable them to understand the risks involved. And we can discuss that possibly later, but the state is that it is still a common practice, and for us as healthcare professionals to enable safer strategies would certainly make a lot of sense. So now I've sort of discussed why it is high risk and some of the guidance around it, but I'll just detail you some of the work that we've been involved in making technology, in using technology to make fasting safer. So in answering that question, the first thing I have to ask is, has technology made other high-risk activities safer in type 1 diabetes? And I'm sure you've all seen excellent examples from your own clinic of people undertaking excellent routines and doing some very impressive things with the help of some of the advances such as CGM. This is Anthony, who doesn't mind being named, as he's published with us his story. That's him running the London Marathon back in 1991. You'll have to trust me on this, but if you focus and zoom in, you'll see one hand is clutching his BM strips, the other hand is clutching his glucose tablets, and he's done it in pretty impressive time frame of under 3 hours. He continued to run half marathons only until recently. He's about 84 now, and he did this more recently with the help of CGM. So clearly, for him, CGM was a game changer, and I think for a lot of people, the use of technology has really helped them to do a lot more things that were previously considered high risk or difficult. And indeed, this example I show here is from an Ironman. Those of you who are not familiar with Ironman means, it's, I think, about 2.5 to 3 miles of swimming, followed immediately by 120 miles of cycling, followed immediately by running a marathon, all back to back on the same day, over a course of 7 hours or so. So obviously quite an intensive and gruesome process, but clearly a lot is possible with the right knowledge, understanding, and use of technology. So how will this apply to a situation like Ramadan? This is excellent work from some of my collaborators, Eba and Ali in Kuwait, where they developed a Daphne model for fasting for people with type 1 diabetes. They very much had the ethos that everyone with type 1 diabetes who, unless they have other complications or complexities, can consider fasting with the right education and with the right tools. And one of the tools they looked to study was the use of CGM. So they used both real-time and flash glucose monitoring. And from their data, they showed that before and during Ramadan, there is actually a drop in hypoglycemia with the use of Daphne, Ramadan, and CGM. And that was fairly powerful in illustrating that with the right education, with empowering the individual and guiding them on the dose adjustments, as well as using a CGM, in this case, not always an alarm-based CGM, you can actually reduce hypoglycemia significantly. Okay, and this is an example from my clinic. This is someone who I actually came across when I was a trainee in Northwest London and has followed me here at Guy's and St Thomas's. He's now 51 with more than 25 years history of type 1 diabetes. When I first met him, he was on biphasic insulin twice a day and trying to fast. At that time, the setup in where we were meant that he was actually in a community diabetes service. So for him to undertake fasting, I put the requirement that he has to change the basal bolus, and that was a huge motivator for something that he was very reluctant to do. He eventually ended up getting referred to myself a few years back, and we undertook Daphne as well and used flash glucose. And this is his data from having had HbA1cs above 9% in fasting to now less than 7%. And the main motivator here was to get himself to a state where he could fast 30 days without any issues or interruptions. And you can see that his time in range of 83%, time below range of 83% is pretty impressive, even outside Ramadan, but with Ramadan as well, and fasting 16 to 17 hours a day, along with a job that he does and 2 children, it is certainly pretty impressive. That's his download data, again showing his day-to-day profile and using the flash system fairly regularly. You can see the number of times he's scanning, possibly a bit too many times, and maybe now with with the updates and flash monitoring in Libre 2 and alarm-based systems, he might be able to hold off on it. But one of the things you will see on the 25th of April, I'll come back to, you can see the Hypo, which is a fairly prolonged one, which often happens with it, where someone may have invested a lot of energy in undertaking a fast, much like undertaking a marathon, and you're obviously going to be very reluctant to break it. And this is a common situation that we see in clinic, and it'll come on to some of the research we've done in relation to this. So just hold on to that image for a second. Coming on to pumps, and I won't have too much time to discuss the entire evidence base for use of pumps in this sort of situation, but just to highlight, obviously with pumps, you have the potential to alter your basal requirements. And certainly one of my colleagues, Nancy Barbari, is a pediatric endocrinologist in Egypt. Her and myself both agreed with this very similar approach when using pumps and altering basal profiles as an initial thought of how you would change in response to fasting and the change in circadian rhythm. And that just basically is, the main thing is reducing a progressive reduction in your basal as the day and fast ensues, because obviously your glycogen stores get depleted, and you want to encourage your glucagon and cortisol to be working maximally, and you're getting a bit of ketogenesis, and therefore you have to end up reducing your insulin to actually avoid a hypo. But then thereafter, immediately after you eat, you will notice insulin requirements go up quite dramatically, and that's where you need an increase in basal. So we talked about CGM, pumps, and indeed now thinking about sense-augmented pump. And in this situation here, Nancy Barry has looked at children, in fact teenagers in Egypt, who are using sense-augmented pump with low glucose suspend. This isn't predictive low glucose suspend. This is a threshold-based suspension of basal insulin. That's not going to completely stop a hypo if it's bolus related, but it's at least certainly going to minimize or reduce it in usual settings. And as we would expect, with predictive low glucose suspender on versus it being off, there's a reduction in hypoglycemia that you can see across, the time below 70 and time below 60 milligrams per deciliter. And certainly that's, again, another profile that you see here. This is from predictive low glucose suspend with using a pump. Obviously in someone with a lot of variability, you may still find that sugars don't quite go to plan, and you may even need small amounts of boluses. This is during fasting over here, and the predictive low glucose suspend kicks in to minimize the hypos, which are difficult to avoid completely, but at least it reduces and minimize it. Okay, so this obviously prompted us to think about, myself and colleagues here at King's, about how should we approach the current guidance, because it does need a bit of an update. And we published this after peer review in the Lancet, in Lancet Diabetes and Endocrinology, about risk stratifying adults with type 1 diabetes who are considering fasting, and actually moved towards a low and moderate risk for individuals who met all of the following criteria, which included HbA1c less than 8%, and we could argue if that's enough or not, multiple daily injections or insulin pumps, and at that time testing 8 times a day using flash glucose monitoring. Certainly now I would insist on using flash glucose monitoring, ideally with an alarm, as that would really help enable and reduce issues that could arise. Being hypo-aware, has received some education understanding around Ramadan, and ideally taken previous fasts first or trial fasts. So certainly a bit like running a marathon. When you've got to run a marathon, you're not just going to get up and run it on the day, but you're likely to take a period of training for the weeks or months ahead. And certainly even in Ramadan fast, I always encourage people who are undertaking it to consider the winter periods when days are shorter to do some trial fasts and see if that and see how things work before they launch into a full month of summer fasts. And then obviously understanding the requirements to break their fasts, if there are any issues, and maintaining a good level of engagement, and certainly other criteria, including the use of pumps or CGM or hybrid closed loops, which might reduce some of the risks we've talked about even further. So that's low, moderate risk, and there's individuals who may be high or very high risks, which I won't have too much time to detail, but self-explanatory. As the HbA1c goes up, or they start developing more complications, microvascular or macrovascular complications, or indeed have hypoglycemia unawareness, then their situation becomes high risk or very high risk. So that's what we've published. We're still waiting on seeing how the international community responds to that at present. But I'll just spend the next few minutes talking about some of the additional research we've been involved in relation to some of the aspects I've mentioned. So in relation to hybrid closed loops, I'm sure most of you are fairly familiar that we're lucky in the UK that we have different flavors nowadays, and a large number of varieties, probably the most in any country in the world. And we may see even more systems coming. And in fact, my slide is already out of date because there's free APS-X for open source or DIY systems, and there's a Metrum hybrid closed loop as well that's available in the UK. So how could these help with fasts? And this is one of the slides from someone who I've supported using a hybrid closed loop system. And in this, for most of you who may have seen hybrid closed loop studies, you will probably see that you get this very nice thin band which relates to low glycemic variability occurring at the night time. And you see that being switched, and you see more glycemic variability occurring at the night time. But what's impressive is you see excellent outcomes. And in this situation, you can see the time in range of almost 90%, with a time below range, apologies, 4.4 here, is certainly in a very respectable position. it sort of inspired us to undertake an observational study between myself and a colleague in the Middle East, and we explored individuals who are using a combination of open source and commercial hybrid closed loops, looking at their data. Obviously, we're not suggesting this is representative of the average person with type 1 diabetes, because clearly these are high achievers on very advanced levels of technologies, but showing, illustrating the potential of using such systems to maintain excellent outcomes with minimal metabolic issues. So in this, you can see here that before Ramadan, an average glucose of 7.3 with very little variability. But as you move during Ramadan, that improves further, if anything, and hypoglycemia at time below less than 3.9 is also reduced, non-significantly, but certainly showing that there's not been any significant change to cause any concern in this sort of situation in this particular group of individuals. This is again another example of showing the sort of glucose trend over the month. This is someone using the Cambridge Artificial Pancreas System, but relating it to insulin requirements during fasts and how the two relate to each other. I won't have too much time to detail this entire picture, but the summary is a very similar total daily dose of insulin in the both fasting and non-fasted states, lower bolus amount of insulin in Ramadan, understandably, because you're eating less frequent meals, low carbohydrate intake in Ramadan as well. However, interestingly, the insulin to carbohydrate ratio was much higher in Ramadan, and most of that increase came from the time of the meal that occurred in the evening called iftar after 7 o'clock. The reasons for that are going back to the slides I showed you in the initial part of the physiology. That you have a very large cortisol secretion. You've got some element of ketones, very mild ketones usually, that may emerge, as well as glucagon release that leaves you in a very insulin resistant state, and therefore you require a lot of insulin to overcome that, to get through your meal. It's less related to the actual carb amount, but it's a frequent issue that we see in people who fast, where they note that they have massive spikes once they have to open their fast if they have true type 1 diabetes. And that often requires a lot more bolus insulin. Okay, so why is this important? Well, actually, this is somebody who I've supported with intermittent fasting. Is somebody who also gets his care in the US and is insured, and uses a DIY loop system with inhaled insulin. Those of you not familiar, this is available in the US and it's pretty expensive, so not funded through us at all, and who follows a 17-hour fast as part of intermittent fasting and metabolic health, as you would, but you can drink during this period, so as tea and coffee. And he's using a DIY loop system, and what he's basically doing is fasting for 17 hours from early evening, went to the gym between 8 and 9, and in fact, therefore, that's why you see a little bit of a spike occurring as a result of cortisol release, and then eating his food with a little bit of a glucose spike, which is actually nothing, but actually, from what we discussed earlier, requiring almost twice the amount of insulin he would usually give in the form of inhaled insulin, which goes in very quickly into your bloodstream. So it's possible that if he wasn't using inhaled insulin, it may even be 3 times. But I'm just illustrating the point here that there is quite a marked stress hormone response, which may cause a temporary insulin to carb ratio change in this sort of situation. Okay, so that's hybrid closed loops, only accessible to a small number of people. What do we do for other individuals? And we embarked on a study using mini-dose glucagon. And this is basically a lower amount of glucagon than what you would normally give in a rescue dose, about 150 to 300 micrograms. Recent data has showed that it's quite useful in preventing hypoglycemia during exercise. It's been also used in children, and subcutaneous treatment does not invalidate fast. So one of my colleagues in Saudi Arabia, Metab, in fact, he was observing. He came over from Saudi to Charing Cross to work with Chana, and that's how I met him. Chana Jayasanad and Imperial, obviously. So that's how we were in touch, and he got in touch and says, you know a lot about technology. What do you think of this? And to me, the big question was, will it work in the fasted state? And that was a very interesting question, particularly as we're embarking on the potential of using glucagon in dual hormone pumps or using it as inhaled options in type 1 diabetes. And that's something we've published, this work with Metab we've published very recently in Diabetes Care, and it's available, and I think Prof has put the links up on the website as well. What we did was a 4-week randomized controlled crossover trial during Ramadan, where everyone got Dexcom G5, that's what there was available in Saudi Arabia at that time, and randomized them to either 2 weeks of mini-dose glucagon as a rescue treatment, or as a treatment, sorry, for hypoglycemia, or 2-week oral glucose tablets, as you would normally use if you were having a hypo. So each person would either have 2 weeks of using glucagon and not using glucose unless they really had to, or 2 weeks of using glucose and no access to glucagon as a crossover trial. So 17 participants were enrolled, and they were instructed to check their blood glucose at specific times, which I wouldn't have too much time to discuss a protocol, but really to do it specifically also when they had symptoms or when their sensor gave a reading below 70 or 3.9 millimoles per liter. And the protocol involved giving a treatment of a smaller dose of glucagon than what we do as a treatment for hypoglycemia if they had a mild hypo or predicted hypo, and giving a much larger dose when the sugars were lower. What we found was, and in fact, I was quite, I was initially unsure, and we retested the analysis and retested the data, and actually it came out true that that mini-dose glucagon actually has more efficacy compared to oral glucose, even in the fasted state. So using the small dose of glucagon not only prevented the hypos, allowed everyone in the group who was using mini-dose glucagon to complete their fasts. It actually was a lot more effective than using oral glucose alone at both the doses compared to both situations. What we also found was that effect of glucagon was preserved even following 8-hour fasting. So when we did the sub-analysis of when the people were taking the treatment, we found that the effect was preserved. And this is quite useful because as we embrace using glucagon in other situations in type 1 diabetes, it's really helpful to know that in the fasted state, its efficacy in preventing hypos, for example, nocturnal hypo, isn't compromised if you're using it in a dual hormone pump or in another setting. So it's an effective treatment and allows more successful completion of fasts in Ramadan. And that goes back to the situation I mentioned earlier of the patient that we were looking after with the very prolonged hypo, which is actually a very common situation that you come across where there's reluctance to break their fasts. And it's something that's very difficult to overcome. So in summary, what I wanted to highlight was that education, empowerment, and advanced technologies, as well as new therapies, can provide effective risk mitigation strategies for people with type 1 diabetes who are fasting. But I think where the risk comes from is more the health, digital literacy, and access to technologies. And certainly there are big barriers in the developing world around this. But even in the UK, where we've got disparities in how expensive treatments are accessed, even in a public funded system, there's certainly a lot of disparities in access. And that probably goes back to the fact of risk. So the risk there is very much down to our ability as healthcare professionals and a system to provide the correct approaches, the education and the tools needed rather than the risk of the condition. And that's in some ways a great place to be in, given the advances we've seen in type 1 diabetes as a whole. So finally, just like to acknowledge some of my collaborators in and outside the UK, as well as just promote some of the technology courses and instant pump course that we'll be advertising very soon in the coming few weeks, which will be hopefully launched now that the COVID period is coming to an end in later on this year. Thank you very much, and happy to take any questions.
Thank you very much. That was a really great talk. Can I just ask, that mini-dose glucagon, why do we think that it works so effectively? And is that related to the small dose that's been given? Is it because it's been given subclot as opposed to traditionally IM? What do you think?
Yeah, so it's working more effectively compared to 15 grams of glucose in the lower dose and 30 grams of glucose in the higher dose. I think it's more to do its efficacy compared to glucose in general, because remember, oral glucose will take longer to act. So some of the improvements, certainly at the 30-minute window, you will see may relate to delayed glucose absorption rather than related to actually how the mechanism is. So I suspect some of that, initial 15 to 30-minute effect is really important in reducing the overall time below range in that period.
And traditionally, we've been taught that after giving glucagon, they should be eating some carbohydrate intakes to reduce further hypos. And from this study, it shows that basically their blood sugar is okay for the next 8 hours.
Yeah, there was certainly no rebound hypoglycemia. If anything, so some of the later analysis we did didn't show any issues with rebound hypoglycemia, and indeed that was a concern we had as well. And certainly I had as well. So one was, in the fasted state, will it work? And secondly, if it works, will it? If they use it in the morning, does that mean late evening they will have a hypo because they've used up the glycogen stores? And actually, it didn't. It didn't really affect the outcomes at all.
A few questions from the chat. Is the mini dose glucagon available to be prescribed?
So this is actually the same glucagon kit that we prescribe, except you have to instruct the patient during the trial to use an insulin syringe to actually dose the right amount. So there's obviously a little bit of education and training around it. There are now mini dose glucagon pens that are easier to use available, and some that don't require mixing and are ready to use. There's also inhaled glucagon that's available as well. So there are other formulations that are now available. But in terms of the prescription for MDG, it would really involve around using a glucagon kit and using the protocol in the paper to guide them as how to draw it up, essentially using an insulin syringe and giving it.
Another question from the chat from Dr. Rahman. Do you think that religious edicts against fasting would change given the new technologies?
So I think they're reliant on us as healthcare professionals to provide the medical risks, and certainly there's work going on in this sort of space, and that's where our role is to advocate, to advise what the medical risks are, and certainly from the perspective where theology comes in and religion comes in, is more about, if it is harmful, then obviously it's something that needs to be avoided. So that's really the bottom line where it comes in, and by no means the work that I'm showing is trying to suggest that everyone should be doing this. Certainly there's no obligation to do it, and secondly, for a vast majority of people you might be seeing, the barriers may well be health literacy and digital literacy and access to the things that make things safer, and if that's not in place, then it's certainly still going to be unsafe for them to undertake that without the right prerequisites.
Can I also ask, from that study with the mini dose glucagon, if they had hypos during the same day, do they then take it twice?
Yes, that's right, yeah.
Okay.
So very rarely was that needed in the particular study, and that still worked.
Any further questions on the chat?
I think there's one from Prof.
It's not a question, really. I think your study is remarkable.
So yeah, I mean, remember, this is a mini dose. So in your the standard rescue treatment we use is 1 milligram. So we're using 150 micrograms or 300 micrograms at the most. And I think to me the main interest was, and I'm pleased that Diabetes Care took the same level of interest as I did, was its potential in being used in the fasted situation, which hasn't been tested previously. And that means certainly when we're using dual hormone pumps, pumps with insulin and glucagon, which are being developed, then in that fasted situation, the glucagon will still have efficacy to avoid hypos.
Yeah, I think it's very centrally important to understand this, because the milligram of, that's just a standard dose, the milligram we've always given. I wonder whether the received wisdom that we've just heard Kavita talk about, which is we must feed the patient straight away, whether that's actually true, I don't know. But I mean, presumably the story that we're all told is that your liver liberates all its glycogen, and so you've got nothing left.
Yeah, so I think a lot also depends on, if somebody's come in with a very prolonged hypo or a very severe, very severe hypo, then clearly they will already have glycogen depletion, and certainly that would be very sensible to give them a meal. And in this situation here, these are all mild to moderate hypos, so you're not completely depleting all the glycogen store with that amount of glucagon or with that amount of hypo.
I think Dr. Rahman has a question. Dr. Rahman.
Hi, excellent talk, Sufyan. I just wondered how many of the patients want to take up, say, flash glucose monitoring or CGM because they have a misunderstanding about, doing finger prick blood testing because they think that might invalidate their fast.
Yeah, so I think absolutely fine with doing that. I think they need, you're right, there will be some misconceptions along this line, and there's again great resources, including from the IMA, that highlights, and this is coming from a more theological background, that it doesn't invalidate fasts at all if you're finger pricking or using a sensor or even taking subcut insulin. Or subcut glucagon in this situation here. So I think it's just making that awareness on their side that it doesn't invalidate their fast in any shape or form. And there's lots of guidance around this to try and dispel those myths. So yeah, in terms of willingness, yes, it's been very strong. If you can, certainly for flash glucose monitoring, that's been really strong in terms of as it makes life a lot easier for them and makes their fast less challenging.
Yeah, can I just say, Harriet and Kavita, thank you for organising it. We're going to have a few more of these as well as endocrine ones. The next one is on the 11th of April, and Alex Comeninos is going to do his usual updated osteoblast and some other clinical endocrine cases, and then we'll alternate between diabetes and endocrinology to have